you've got to take decisions, you know, and you can be very risk adverse in the public sector. You've got to take decisions. Sure. And I'm very much, when we got to Fiona Stanley, it was behind. We actually needed to get it up, get it running, make decisions. And I remember said to people, this is commissioning a big hospital. We're going to get some decisions that are wrong. They're not wrong because they're made on the right advice at the time. And if they're wrong, we'll redo them. But if we don't make a decision, the hospital won't open until 2030. That's crazy. These are difficult times. That's sometimes quite hard. And you say to your team, I've got your back.
There is rarely a life untouched by hardship or challenge. On this podcast, we invite our guests to share their very personal stories. We harness the wisdom and resilience of our guests, which has shaped who they are today.
Carl Rogers said, that which is most personal is in fact most universal. Together we'll be inspired to embrace the resilience in our own stories and to gain strength in the face of adversity and have a few laughs along the way.
Hi, I'm Donna.
And I'm Di. We are the Double Ds and welcome to the Discovery Diaries.
We acknowledge the Whadjuk people of the Noongar Nation as the traditional custodians of the land on which we are recording this podcast. We pay our respects to the elders, past and present, and acknowledge their spiritual connection to family and storytelling.
Both Donna and Di were born here on these lands. We are grateful to draw on the culture of telling and sharing stories, and we hope that you will draw inspiration from the stories that are shared here.
Today's episode is with the former Director General of the Department of Health in Western Australia, Dr. David Russell-Weisz, better known as Russ. Dr. Russell-Weisz is the former Director General of the WA Health Department, a position he held from 2015 to 2024. Dr. Russell-Weisz graduated as a doctor in Scotland. He is from an area very close to Di, where Di spent many years, but has spent the best part of his professional life in Western Australia. He discusses this in quite some detail in the podcast about how he moved to Australia in 1993 and joined the Royal Flying Doctor Service in Broken Hill, and then moved to Western Australia, where as a procedural general practitioner and then Director of Medical Services, he served communities in regional and remote parts of Western Australia. The work gave him a special appreciation of the challenges faced by those delivering services in rural and remote areas of Western Australia and the unique responsibilities of our state's health system in achieving equitable health outcomes. He also talks a lot about that in the podcast. Later, as Chief Executive of North Metropolitan Health Service, he led the $1 billion redevelopment of the QE2 Medical Centre. He also talks at some length about the commissioning of the state's flagship $2 billion Fiona Stanley Hospital, which opened its doors to its first patients in late 2014. As Director General, Dr. Russell-Weisz steered the public health system through a period of significant reform, and among many other things, he was involved in the commissioning and opening of the Perth Children's Hospital and was also responsible, one of the key people in charge of the state's response to the COVID-19 pandemic, which he goes through in the podcast as well. So we've got a very interesting podcast today. It's been a real honour and a thrill to get Russ in on the conversation. He covers all sorts of topics about his career, about leadership roles when you're in a technical position in health, and also he speaks about what he sees as the top health challenges going into the future. We're very privileged and we really thank David Russell-Weisz for coming along today, and we hope you enjoy this conversation as much as we did. If you do enjoy this episode, please follow us, Double D's Discovery Diaries, and share this episode with friends and colleagues. Well, welcome, Russ. It's great to have you here on our podcast today. So our listeners probably don't know that Di's actually spent decades in Scotland, and before we started recording, you were talking about your childhood in Scotland. Did you want to tell us a little bit about your background and how you came out to be in Australia?
Yeah, look, thanks, and good to be here. I think it's always important, I think, to to talk a little bit about all our backgrounds because they influence us so much. But I was born in Scotland. My My parents had lived in the borders for, over 35 years. My dad was an older father. He was 56 when I was born. Mum was 44, so quite unexpected arrival. And Dad had come from Vienna in the early 30s. I met Mum in the borders, and he was in the textile industry. They lived in Scotland, they worked in Scotland, but they eventually retired to Jersey in the Channel Islands, and I went to school in England, hence the Scottish accent, which I'm assured I had, has gone, and now I have a sort of a hybrid Australian Pommy accent. But yeah, so I grew up part of my early life there, and then in the Channel Islands, and then I went to school in England, and then went back to university in Scotland. So I did my medical degree at the University of Dundee. It was a great 5 years. We're very, very lucky. We had a brand new, in those days, medical school, the University of Dundee and Ninewells Hospital, brand new hospital there. I should have known then. I'd be then, looking at commissioning new hospitals, but didn't know that then. And I then went down to London, did my early training in London, and at that stage did my general practice, vocational training. So it was a couple of years in hospitals and 1 year in general practice. Worked in a very low socioeconomic area in South London, and then did nearly 2 years of anaesthetics. And it was really with a view to coming back out to Australia, because the Australian connection had happened when I was a medical student. And as a fifth year medical student, you could do electives anywhere in the world really for about 10 weeks. So people chose, my greatest friend chose Jamaica, and I'd seen that a guy I knew a year above me, had gone to a place called Burke in New South Wales and had a great time. So I wrote off to them and said, look, could I come out? And I'd organised some time in Burke and also in the Royal North Shore Hospital in Sydney, and went out to Burke and was completely blown away. Probably two huge influences in my life were the two GPs I worked with, Mark Harris and David Sutherland. They did everything. They taught me heaps. I loved the Outback. I loved the ability that you could, as a clinician in the Outback, you were part of the community. And I'm not just talking about doctors. I'm talking about the nurses, the midwives, physios, everybody who was part of that community. And I absolutely loved it. I stayed there longer than I'd actually planned. And I think that really gave me the love for Australia and the love for the Outback. So then when a job came up with the Royal Flying Doctor Service in New South Wales, based in Broken Hill, I sort of finished my couple of years of anaesthetics, and this had come up, and this looked really too good to be true. And that was in sort of 1993. I had a great blessing from my very elderly parents at that stage, especially my dad, to go out there. He could see why I love the place. And I went for an initial year, and I'm still here. So, and I think in those days it was quite hard to stay in New South Wales. The reason I ended up in Western Australia is, as an overseas trained doctor, you were restricted, and certain states had significant restrictions. Really no idea why, because, it was so hard to recruit to rural and remote, as it is to this day, but it was, I think, even harder then. Yeah, so I had some friends in Western Australia, and got in my car after my 2 years, drove across here and started doing some locums. Excellent.
And you couldn't have picked a more outback town than Broken Hill, and working for the Royal Flying Doctor Service. How did you find that?
Oh, I think, I have to say I absolutely loved it, and I did. It was a mixture of general practice, emergency medicine, community care. There was a bit of everything. I made some great friends there. With the pilots, with the nurses, it's a huge camaraderie between the team. You can either be on the clinic run, so you see a lot of Aboriginal health, you see a lot of rural and remote health. So you visit some. I always remember the communities of Tibooburra, Louth, Wilcannia, Ivanhoe, and then you serve some of the mines like Moomba. So it's very, very diverse. So you can do what I would call pure general practice. You also get, my eyes were completely open to the world of Aboriginal health. Coming from the UK, I had very, very little idea. There was very little orientation in those days. And I think one of the great influences in my time there was actually the Aboriginal health workers in Wilcannia. Now, they weren't called Aboriginal health workers in those days, but I was blessed to have two very, very passionate ladies who taught this slightly dorky doctor from the UK about Aboriginal health and you see it's just not comparable to anywhere else. And, then you had the mixture not only of general practice but Aboriginal health, but you also had the mixture of emergency medicine. So you could be on call for a weekend or for a week, and you're on call with a nurse and with a pilot, and you could be called to road traffic accidents, to literally anything, to medical, surgical emergencies in that area. Our main town that we took patients to was Adelaide. So whilst Broken Hill's in New South Wales, only 50 kilometres from the border. So the main sort of town that you went to was Adelaide. Very, very rare you went into Sydney. We did go into Dubbo, and usually then we do a switch of planes and crew with the Sydney branch of the RFDS. But look, 2 years, huge, and can I say, a beautiful scenery. If there's anything I think that hooks people from overseas to this great country, it is the Outback. It is, and I can remember landing on strips in the middle of nowhere, and I always remember in the very early evening, and that just feeling of space, the absolute feeling of space, the heat of the space, it's just extraordinarily healthy. And because I love flying, I learned to fly as a private pilot in Broken Hill. So I got my pilot's license then, but I didn't fly for the RFDS. They have, commercial pilots who fly for them, and they leave me to do the doctoring.
I'm really struck, Russ, by, until you've kind of experienced being on country, it's really hard to describe. You have to kind of be there and connect with it to in any way come to a sense of what it might be like to have been born on country and then to be, connected to it in a particular way. And, you come from overseas, come from England in, a Wadjala world.
Yep.
And I wonder, what were you struck by in terms of our Indigenous friends, their connection to country?
If I look now 30 years on, I think I was struck by it, but in a way that was so much more tangible because I was working with people on the ground. And we saw not only did you see significant disadvantage when it came to health outcomes or even health service delivery, but I have to say I was very much welcomed in. I was open to learning, and I've actually been blessed over the last 30 years, even in my period as Director General, I had an extraordinary Department of Aboriginal Health led by a Director of Aboriginal Health that I learnt a heap from, and I'm continue to learn from. So, yes, I've learnt a lot across the years, but there's a huge amount for us, for everybody to keep learning. I think it was going back to that, your question it was absolutely tangible. It was tangible, the connection with people to country and different. And I talk a lot about Wilcannia because I spent a lot of time there doing clinics, but it wasn't just there. It was everywhere. Some of the communities within that environment, but you get the very tangible experience of Indigenous people, having that link with country that maybe non-Indigenous people find difficult to understand, but it is real, it is there, and it affects everything. It affects employment, it affects family, it affects health, it affects social well-being. And I think we have to accept that, and we have to work with Indigenous communities, not do things to Indigenous communities, work with them to find the best ways forward in relation to their healthcare.
So you did go up and work in other remote Aboriginal communities after FDS?
Yeah, when I came here, I actually just signed on with the locum service, the AMA locum service, and it was me. I was single, and it was me and my dog. And they said, well, where would you want to go? I had anaesthetics, so basically I could do some procedural work. And I said, look, I'm happy to travel. And I was very lucky. They sent me, basically to doing short locums initially around the wheat belt. I went to Geraldton. I also did some locums in the southwest. I spent quite a bit of time in Australind when it was very, very small, not like it's now. Worked at the old Bunbury Regional Hospital. And then after about 6 to 7 months, I got to know what was then known as the WA Centre for Rural Remote Medicine, or WACRM. There are lots of acronyms in health. Sorry, I'll try not to use them today. But WACRM, now it's Rural Health West, and the late Dr. Brian Williams, was, again, a huge influence on me and was very supportive of what I wanted to do. Professor Bryant Stokes was the chief medical officer at the time, and they said, well, we know you want to stay. Would you go to Port Hedland? And I said, yeah, I'll go to Port Hedland. I knew where it was. I hadn't actually gone up to the northwest. They knew I worked in Broken Hill for 2 years. And there was the senior medical officer job up there, which was half-time administration, half-time clinical. So I did anaesthetics, I did general practice in the hospital, and obviously emergency medicine. You had to do everything. And also was the senior doctor at the hospital. And I'd sort of got into the administration, management, leadership world actually through Broken Hill, because in Broken Hill they'd gone through a series of chief medical officers. When I was there for the 2 years, one chief medical officer left, and they asked me to step in. And to step into it was quite a difficult environment. And I got a real taste for leadership, and that obviously has remained with me. I'm a huge believer in clinicians, and when I talk about clinicians, I'm not just talking about doctors. I'm talking about any clinician actually wanting to get into management administration, and it doesn't matter whether you lead a small group, so you lead a department of cardiology or a department of physiotherapy, or you lead a hospital, or you lead a health system. It's all critically important to actually encourage those clinicians who want to have a bent into management and administration. And so I spent 4 years in Port Hedland, absolutely loved it again. It was an extraordinary 4 years. People think about Port Hedland, and, because a lot of Australians said to me, why are you going there? And I said, well, it's where I've been offered a position, and I absolutely loved it. And I spent 4 years in Hedland and 4 years in Broome, and Hedland was really friendly, really welcoming. You all knew each other. Not everybody, I don't want to make it quite like that, but there was a real camaraderie and in the community. It's not the most attractive town on earth, but it
still isn't. Actually, I wouldn't say.
But it's very attractive. I loved living there. And beautiful scenery. The Carragini in those days, you could actually drive in. It wasn't, it may have been a national park, but it wasn't as organised as it is now. And then got the opportunity to go to Broome as the Director of Medical Services for the Northwest, and that covered the Gascoyne, so it covered Carnarvon to Kununurra, and I was based in Broome. And by that stage, I'd met my wife, and I dragged her back to Port Hedland. She'd been in Port Hedland before. She met me in Perth, and she said, "Where do you live?" And I said, "Port Hedland." And she actually didn't say no, so she came back, and we spent I spent 8 years up there, and we were in Broome for 4.
Fantastic. My husband actually lived in Port Hedland in the 80s for 8 years and absolutely loved it as well. He said there was a very big community spirit.
Yeah, and I think to this day I meet, junior doctors and more senior doctors who spend time up there, and they all love it.
And again, I think there's that sense of the words community, rural, garners people around community in a way that we don't necessarily see in the cities, and it's actually what often holds people in places that are more remote is there isn't any other sort of sense of community quite like it.
Oh yeah, and I think I can be a bit irreverent at times when, and especially when I got to Perth. When I came down to Perth and I worked at King Edward, and they said, "Oh, your human resources manager will be in to see you." I said, "What's one of them?" Because in rural and remote, you sort of did everything, and you shared everything as well. And I think sometimes we do need to say to those people in metropolitan Perth who have never been out to rural and remote, and I use regional as well, so but never been to rural and remote, it is so much harder. You do have to be a bit of a jack of all trades. You do have to be resilient, and you are delivering, if it's healthcare, it can be healthcare, it could be education, in some very challenging environments.
This episode is brought to you by Impact Society. Impact Society is a company focused on helping everyday managers become world-changing leaders. They provide straightforward and stylish tools, training and content to elevate leadership skills and mindsets and help leaders thrive both at work and in life. I personally know the company founders, Sean and Joel, and they have set up Impact Society as they saw a gap in the market for leadership training for technically based staff that wasn't as expensive or as lengthy as a MBA or other leadership courses at university. So essentially they've scratched their own itch. They both come from technical backgrounds, and then Joel set up his own consultancy company, and Sean has been in diverse leadership roles in government and the private sector. We are especially excited about Impact Society bringing you this episode because they have a new product, a strategic planning toolkit, which is designed to help leaders put in place a straightforward strategic plan that any organisation or team can follow. As many of us know, strategic planning is not the easiest or most straightforward thing to do. So this toolkit, I've had a good look at it myself. It's completely clear, easy to follow. There's checklists, there's emails, everything you could need to put in place a strategic plan. And for our listeners of the Double D's podcast, there's a 20% discount on this strategic planning toolkit. You just need to go to impactsociety.co, and in the discount code, when you purchase the strategic planning toolkit, you put in the discount code Double D's, so Double DS at the checkout, and then you'll get your 20% discount. So we would encourage anyone, especially people who are new into leadership roles, to check it out.
And Russ, when you talk about resilience, people have to be resilient in those jack-of-all-trade type scenarios. What do you mean by that? How does it show up?
I think it's a great question. I don't think you have to be I'm not saying you have to be tough. That's not the word I'm saying with resilient. I'm just saying adaptable, ability to get on with community, not to have everything so scripted, because it can be extraordinarily relaxing. We now have a place in Ocean Beach in Denmark, and I remember when I was in the jobs which were stressful I had here, that was a really great bolt hole to actually, the country is less stressful. But I think it's the resilience is about that adaptability, working with community, and it's sometimes not one size fits all. So, but I also think the resilience it brings is I've seen, people who, let's say, are not keen to go to rural and remote yet love it. When you taste it, when you see it, it is so much different, and you bring so much back. I always talk fondly of my country health service time. It's in a sense it went too quick. But
that sounds very formative for you in your practice and in your experience. And I'm struck by what you said earlier, which is you had some colleagues around you who knew the direction that you wanted to go, and then you went up to Port Hedland. But did you have a sense in your career that you knew where you wanted to go, and or was it a wee bit more winding and accidental than that?
I think very winding and accidental. If you'd asked a medical student in a final year medical student in 1987, I'd be running the WA health system for nearly 9 years. I would have said certainly not. But I think also it's actually quite good being accidental. When I had that time at RFDS, and then I ran the hospital at Port Hedland, and then I became the medical director for the health services, I knew I had a real like for administration, for management, for leadership. And what I did, I said to myself, well, if this is something you want to do, you've got to go and get trained. And so I went to do a Masters of Health Administration. I was supported by the Health Service. I did that in New South Wales. I then did my fellowship at the Royal Australian College of Medical Administrators exam. So I got my specialist qualifications in medical administration. And recently then through the Australian College of Health Service Management as well. A bit like, it is important if you are going to take a role in management and administration. It's a bit like being a cardiologist or a GP. I got my fellowship at the College of General Practitioners, because I was trained as a GP, and you got your specialist qualifications. You should think about the same way if you're going to really forge a career in large, complex projects or health systems. And so I think by the time I got to Broome, I saw myself having a career in leadership positions. But even then, I was not thinking, I'd be the Director General of WA Health. So I think that came later.
What would you say, Russ, to clinicians who are way younger and more junior at the moment, and they might be thinking, how do I figure out whether I should look into these leadership administration type roles? Because I would imagine it'd be quite a move from if you've done your training in a certain field.
I would say to them, put your toe in the water. If you're interested, talk to a colleague, because it usually starts, if it starts in a metropolitan hospital, it usually starts in a department. So it doesn't mean a lot of clinicians don't want to give up their clinical practice, and I don't blame them. I think the very key thing, and what helped me, was having clinical credibility. I'd worked as a clinician for many, many years. Now, I don't work as a clinician now, and I haven't for quite a few years because I haven't had the time. So I've made that. A lot of clinicians who go into medical administration, management leadership positions eventually have to say, well, that's enough. I'm not doing enough clinical medicine to remain current, so I'll make that move. But that doesn't have to be in the early days. And it actually doesn't have to be even if you're running a small department. You can still remain clinical. Say if you're a physiotherapist, you can still run a department and still have a clinical load. And so I think I would always say to somebody, put your toe in the water. Find somebody that you know that's done it. Talk to those. There's plenty. There are now, from when I started, there's many, many more tools. So there's toolkits, there's skills you can go and get. We have a really robust Australian College of Health Service Management in Australia. It's actually run from WA. It started significantly from WA, and its current president is an ex-Director General of Health, Dr. Neil Fong. And it's very, very practical. And you can actually make it practical for yourself if you're saying, like, if you're a budding clinician manager, and there are courses. You don't have to go and do a master's. You can do small courses. You don't have to do any courses as such if you want to just put your toe in. But it's not for everybody. So again, not everybody has to do it. And the other thing you can do if you're a clinician or a full-time clinician in whatever field is you can take some projects on that you'll get some administration, management, leadership skills. So there's lots of ways to do it. As I said, you don't have to be chief executive of a hospital and you don't have to be director general of a health department to have made it in health administration.
Yep. And so you have been Director General for 9 years. When you've left in March, late March, sort of reflecting back, what are some of the highlights and some of the projects or the things that happened that you really think I needed a lot of courage and resilience for these?
Well, I think before I became Director General, when I came down from Broome, I had an opportunity to go, the medical director at King Edward was going overseas, and she asked me, do you want to come down and do a year as a medical director of King Edward? And it was time. And so we decided to come down. That was very influential. I worked with some great people at King Edward, but it was only a couple of years after the Douglas inquiry, which was a significant inquiry that I'm sure some of your listeners will remember, into the outcomes of care given at King Edward at the time. So it was a very interesting environment to go into. And I also worked at Princess Margaret at the time as the medical director, and then a position came up at North Metro, and by 2006 I was the chief executive of North Metro. And I remember the chief exec at the time, John DeCampo, said to me something that's remained with me throughout my career, because he left, he went back over east, and he said, it's time, you need to be the chief executive of North Metro. And that was a massive step up, because that was running 3 tertiary hospitals, 3 secondary hospitals, as they were known in those days, a budget of maybe $2 billion. We were doing significant redevelopments, and it was just seemed a bit soon. And I remember saying to John, and John saying, no, you're ready. You're ready. And he said to me, it's lonely at the top, but you get used to it. And I always remember those words. And it is a bit lonely, but it's actually not too lonely, because you do have loads of colleagues and you have a network around you. And so that was North Metro for 6 years. We did a lot of the infrastructure redevelopment that you now see at the QE2 Medical Centre. We expanded, we oversaw the expansion of Joondalup Health Campus, the first expansion. And then I was asked by the then Director General to go to Fiona Stanley Hospital to take over the commissioning. And that's one of my, I suppose, before I sort of put it all together in the Director General job as well, although I wasn't the DG. You couldn't do both. I was the Chief Executive Commissioning of Fiona Stanley, and I loved that role. I loved, actually, and I still get goose pimples when I go through that hospital, because when 2 of us, my great colleague and friend, Liz McLeod, who was worked with me at North, and she and I were asked by the then Kim Snowball to go to Fiona Stanley to take over the commissioning as a discrete project. I remember we went down there middle of November and we got put out in 2 dongers out the back, and you either had the air conditioning on or you didn't, because, you wanted it on because it was so hot, but you couldn't hear it.
Lucky you'd done a stint in rural Australia to get used to those dongers.
I think I got a bit soft though by then. So we, that was starting from literally a few staff, a commissioning team and an empty hospital. You go through that hospital now, there was a wonderful commissioning team that I had the real pleasure of leading, and we brought that hospital to life. And now you wouldn't know it. So I walked through it, and I still remember the days where you walked through it and there were literally 4 or 5 people walking through the hospital. That was it. The hospital was built and we were bringing it to life clinically. So you asked, Donna, what was one of the things I reflect? Look, we had lots of front page news. We had loads of challenges, as you do in the health sector. This was the largest hospital that WA had ever done, 810 odd beds. And look at the site now. You've got 810 beds down there in the public sector. You've got Murdoch University next door. You've got St John of God Healthcare, which expanded from, I think in those days, 350 to now 600 beds. You've also got that huge commercial district and medical centre district being developed to the northeast of the Fiona Stanley site, or between the 2 hospitals. It is great to see, because that was about care closer to home. It was about, no, you don't have to come to QE2. No, you don't go to Fremantle. You don't go to Royal Perth. They're all needed, but you do need a central health service hub in the Southern Corridor. So I look very fondly at that. I've probably forgotten some of the scars and some of the issues that we had. I remember getting blamed, not getting blamed, but it was a good front page story where we were in the firing line when actually there was an argument between the 2 telco companies and nothing actually to do with us about what antennae you put on the roof. And then I suppose I'd been asked a couple of times, would I go for the Director General position before that, and I said, no, it's not time. And I think that's another thing I'd say to budding people. Don't do things too quickly. Don't do things when you haven't got the experience. You do need experience. Theory is one thing. It's not everything. Experience is significant.
What were you aware of in yourself, in your own leadership or your experience, that felt like, no, I need more time? You obviously had a sense of that for yourself, that you weren't ready yet.
Well, I think also, firstly, when I took the Fiona Stanley Hospital job over, Kim Snowball, at the time, the Director General, he left soon after that. And I was committed to Fiona Stanley. I wasn't going to go for the DG job at that time. I also think I just knew I needed experience. I needed to get as much experience out there. I'd rural and remote. I'd run the North Metro. I'd run hospitals. I was now commissioning a large hospital, and we had a very, very large infrastructure program. And I think sometimes it's not as simple as written down on a bit of paper. It's in your gut. It's a bit like when I decided to leave. It was really in the gut. It's not 100% to 0% decision. It's usually 80-20. But I think it was just it was to get that experience on the ground, as much experience as you can, because as a Director General, also, to be frank, Director Generals of Health usually only last about 2.5, 3 years. And so when you're actually thinking about taking it on, they're not, in the past, they're not long. They don't have a lot of longevity. And I was thinking, not it should be to the back end of my career, but I should have as many tools in my toolkit to be able to do the job as well as I could. I loved the job. I did it for nearly 9 years. I signed a second contract. I think it was on December the 6th, 2019, and we know what happened in January 2020, and then COVID came. So I think it was important just to talk a bit about North Metro and FSH, because they had a huge influence on me as DG.
And I imagine at that level, and I have a bit of experience from coaching fairly senior leaders who, have learned certain things that they're not very good at as well, and how you really draw down on those around you. So I wonder, what would you admit to in terms of what were some of those things that actually had to be quite bold about, the things that weren't in your toolkit and you really relied on team around you?
Well, I think you've said it. It's the team. I have been blessed again by building good teams. I have had some great people to work with, people say, what do I miss at the moment? I probably don't miss the relentlessness of the job after 9 years, but I do miss the people. I had an amazing team of people in the department, at the health service provider level, and I think I've tried at all times to build teams. You do not have to be an expert in everything. I can give one example. When I went to Fiona Stanley Hospital, I was very worried about my knowledge with ICT or digital. I'm just a boomer, just by the cutoff, 1964. So didn't grow up with it. My kids think, when it comes to me and, sort of the iPhone, I'm a dinosaur. So you know the story. But what it taught me, while I was very worried about it, it taught me to get a good leader in there, somebody who had the technical skills. And what I provided was to try and bring all the different streams together to get to an outcome. So I think leaders or senior leaders of organisations have to be able to get the balance of operational, strategic, have to get a team that brings different skills together to meld them together with a goal to get everyone on the same page. But there's no way that I can be a workforce expert, a digital expert, a clinical expert, an infrastructure expert. With Fiona Stanley, we had, and as a DG in health, we were lucky, not just lucky, we grew that team. And also you have not just at the next tier, right the way through organisations, I can think about people who you would never heard of within the health system, that without them, we would have been in a worse state. And you've got to have good teams to actually, and that's not just teams of administrators, leaders, it's teams of senior clinicians, senior doctors, nurses, physios, dietitians, all other allied health, midwives, nurses and midwives. You need good people at every level because health never switches off. It's 24 hours a day. So I think you probably, in your question you've asked me, it is about teams, it's about good governance, it's about knowing the scope. And I think as Director General, you had to have I think in every senior health position or leadership position, you have to have an ability to work with governments, both state and national governments, being able to work well with them, not always agree, but work well, know that you are a public servant and you serve the government of the day, but also know that you've got to have an empowered workforce. But without an empowered and a happy workforce, and health has been strained with COVID, hugely. No other workforce is strained as probably the health workforce. Without an empowered and happy workforce, you won't get good outcomes.
This podcast is brought to you by my business, Coming Up for Air. That's Coming Up number 4, Air. This is a business which cultivates curiosity, compassion and courage through executive coaching, workshops and leaders' retreats. Donna, you've been to one of my retreats.
Yes, and as a senior leader, I decided to invest in myself and go for a day. It was on the weekend, a full day retreat. I'm so glad I did go. It was just what I needed in my life at that time. We spent time on our own, reflecting on questions that you gave us, Di. We spent time with others there, being creative, which I don't often get the chance to do in everyday life. And my absolute favourite part was spending some time with the horses that were on the property. The horses have such a calming effect, and I just left the retreat feeling completely rejuvenated and had time to think about some important life questions that you don't usually take the time out to think about.
Thanks, Donna, and I didn't pay her to say that. I do run retreats at various times through the year, which are open retreats, ideal for leaders, just as you said, Donna, to get away from the busyness of work and life, and often we don't take this time to invest in ourselves. You can find me on Instagram or at comingupnumber4air.com. And I'm really curious, Russ, about how in the midst of all of that, political side of things, all the external stakeholders and internal stakeholders that you're trying to keep happy and build your team, what kept you connected and grounded to what really mattered when it could be easy to, be swept away with some of that? What keeps you or kept you grounded?
I think there's probably two prongs. On a personal perspective, it's your family. They keep you grounded, because I can tell you my family are not particularly interested. I've held any senior leadership position. I'm either, somebody who doesn't get home on time, or I'm a dad. And, your kids are they bring you down to earth. So I had great support from the family as well. I actually asked my son, because he was, I think, about 10 or 11 at the time. He was 11 at the time, about doing the DG job. And I remember him saying to me, well, I was thinking, Dad's thinking about this. And I remember him saying to me, well, you may not get the opportunity again, so you should say it. You should do it. So I think on a personal level, it's very much like family. It's also making sure when you're at work, your team speak out, that they're free to speak out to you where they think you're taking the wrong course. And also, I think having humility and humour. As a leader, especially in difficult environments, you do not take, I get this from my parents very much, because do not take yourself too seriously. And also bring some humour, bring some levity to the leadership role. These are tough roles. Yes, you're talking about people's healthcare. You need to be serious. It is absolutely right. But these are tough, and I think we learned it through COVID. COVID was probably one of the toughest things. Health and actually the community. The whole world did. So that's what I try, and that's what grounds me. I mean, I have my own in my health. Donna will know this, because we run around Floria Oval, being chased by Carol, our trainer, every Wednesday. And I think the other thing is have your own, if you've got a leadership position, have your own type of meditation. That could be running, it could be swimming, it could be something else, and also have time out. You do need time away. Nobody is indispensable. I'm not saying I do that very well. I'm not saying that the phone is not attached to or wasn't attached to my hip. It's no longer attached to my hip. But, and also, know who you work for, know your stakeholders. I've been blessed by working from some outstanding ministers, and I think as a leader, as a director general, as a senior leader in any government agency, you've got to be able, you're that person who's got to be able to work with ministers, and also got to work with your team, and also be able to work with, with the broader team. There are 55,000 people in health, so you clearly don't know everybody. But you've got to be able to translate good policy into good operations and give good advice at the same time.
What did you find was, with these big projects and big challenges, what did you find that sometimes you kind of struggled with? Was it the enormity of the amount of stuff you had to do, or was it trying to make the right decision? Or
I think I think the decision point, I'll take that first. It goes to your question. I think one thing I found with Fiona Stanley is you've got to take decisions, and you can be very risk adverse in the public sector. Got to take decisions. Sure. And I'm very much, when we got to Fiona Stanley, it was behind. We actually needed to get it up, get it running, make decisions. And I remember said to people, this is commissioning a big hospital. We're going to get some decisions that are wrong. They're not wrong because they're made on the right advice at the time. And if they're wrong, we'll redo them. But if we don't make a decision, the hospital won't open until 2030. That's crazy. These are difficult times. That's sometimes quite hard. And you say to your team, I've got your back. We've got your back. Because those are, I think, especially when and COVID was a bit like that, actually much more, because you were taking decisions, we were all taking decisions the whole time, and some had to be redone. And I think that's okay. I always remember one very diligent project officer at Fiona Stanley saying to me one morning, and I remember she was very upset because something was on front page news, and they weren't being very pleasant to the Fiona Stanley team. And I spent a lot of time with this person just saying, you're doing a great job. This is not what's being reported. Yes, it is a view. This is a high-profile project. It's a bit like being a high-profile individual in the sense if you're in a senior leadership position, you are going to have some scars, but you should be there if you're a chief executive, director general of a public sector agency or an area. You should be ready. You shouldn't do that if you're not prepared to take some of the really hard times that come with the good. And that goes with the experience. So I think that was take decisions. Don't be afraid of taking those decisions. I think the other thing is, yes, sometimes the enormity, sometimes you get a bit overwhelmed. I say to and I'm sure every leadership guru says, oh, get on the balcony. Or the other thing I love hearing is every director general should spend 70% of the time strategizing, not doing operations. Well,
haven't met one yet.
Yeah,
that's a big figure.
That's a big figure. And also, it's not really realistic. You've got to be able to, in COVID, we were very, very operational and probably less strategic. But, you've got to give yourselves the armory. I use the armory or the toolkit to be able to do that and be able to be adaptable to when times, as they have got better outside COVID, to be able to move to, right, what are the more long-term things? Actually, COVID, we were extraordinarily innovative. There were, not just health, there was education. Everybody actually innovated much quicker than they did prior to COVID. And we don't want to lose that. I mean, if I look at telehealth, if I look at telestroke, I'm sorry, I'm diverging from the topic, but it is about the decision. And I think some of the things that I found a bit overwhelming was the enormity and not getting on that balcony sometimes to go, sometimes you needed time out to say, how are we going to solve this problem? And because you were in a bit of a washing machine, you could probably never get out. And sometimes you had to go and phone a friend. You had to have some other way of finding a solution or not trying to fix it. So one of my weaknesses is, and I've had to learn over the years, and sometimes it's a strength, is actually going to fix something. You see a problem or you want to fix it, but you want to move on to something else. Sometimes you've got to stand back. Also, not necessarily fix it. If it's been delegated up, why has it ended up at the senior person's desk? What are the options that you can, if you're talking to somebody, that you can fix it? And also not rushing in to do it, actually taking a bit of time. Not with everything, because I'm not very patient. I'm not a patient individual, especially because I know if something can be fixed today, you've got other issues that are coming tomorrow. I think some of the other issues you say, which are probably more annoying, but they're still there, is a thing where problems have been known, say on a Monday morning, and the senior person hears about them on a Friday at 4 p.m. I always had no surprises. No surprises for government, no surprises for minister, no surprises for me. So if there's something out there, let me know. Certainly learnt that through Fiona Stanley, let me know, and also through the Director General job. If we can resolve it or the issue is really not an issue, that's fine.
But I think that also really speaks to that culture that you try and build, which is we're doing the best we know to do at the time, and mistakes and risk comes with that, as opposed to being so paralysed by not making any decisions. And they kind of go hand in hand.
Yeah, I mean, health, naturally, it's a 24-hour business and it's not just about hospitals, and we've talked a lot about hospitals. It is about community care. It is as in the care we give to the people tonight at Fitzroy Crossing, for example, is as important as the care that we give to those at Royal Perth Hospital. So, it's a very diverse system. Community care, you've got right through tertiary, quaternary hospitals. And at the same time, while health does its business as usual, which is treating patients today, making sure that patients are being seen at the right place, the right time, and get the right care, you're also got all this health infrastructure you're planning for the future. So we did put in place, state government put in place a sustainable health review. And out of that, we put a digital strategy in place that's there for 10 years. We have got a clinical service framework that sets the clinical. We've got a workforce strategy. So you do need to spend time on those so that people can see you have got a blueprint for the future and a roadmap for the future. I'm not saying that we always stick to it. You can get taken off on tangents, even without a pandemic.
What would you see as some of the big health challenges for the next 10 years?
Oh, that's a great question. Look, I think worldwide, clearly the ageing population, you've got increasing chronic disease, you've got some prevention issues, you've got some public health issues that are of significance, and I talk about vaping here. So I think the two major three public health issues to affect us all are going to be vaping and smoking together, are going to be obesity and also climate change. And we have to treat vaping, and I think what is great is governments, and this Commonwealth government especially, are treating vaping just like smoking. Vaping is the new smoking. People are trying to get hooked on vapes, so they turn to smoking. There's no doubt. So you don't gild the lily. You need to attack this. And I think it's one of the major issues affecting us. The obesity epidemic that's here, there are more people obese than there were 10 years ago. That is going to lead to more chronic, yes, it leads to death as well, but it leads to chronic disease. So I think the things that are the clear issues that are going to affect healthcare in the future, the ageing population, more chronic disease, and also the demand for healthcare. So you can see that because the demand's at the front door and it's also at the back door of hospitals. It's in aged care, it's in long stay. And it's not just about, I put a lot of effort in as DG to look at that, sort of working with the aged care sector, because it's not just about aged care, it's about the disability sector. It's about, you want people to go home, but sometimes it's not as simple as that. It's actually, it needs other agencies to cooperate, it needs housing, needs disability, needs aged care. So I think those are the ones that are affecting broadly every health system around the world. Clearly the cost of healthcare, we're now 30%, we are, most systems are 32% of the state budget. And if you look around the world, health budgets are increasing. There is more pressure on health than probably anywhere. So I think in Australia, you've got two different systems, and I actually think there is good collaboration between the Commonwealth and the states. Generally, during my time as DG, I chaired the Health Chief Executives Forum, which was all the Director Generals for a couple of years. And we do a lot of a national level. We don't see it so much here, but ministers collaborate at a national level. There is a real tangible working together. And I think that we'll need to do that more. And what we can't do is say, general practice is the purview of the Commonwealth and the hospitals are the purview of the state. If you do that and they're not intertwined, like public healthcare and private healthcare, we won't win. We're hiding to nothing. We have got to get that system more integrated. And I'm not just using that word. I don't particularly like that word because it's used a lot. But we need tangible, pragmatic solutions to be able to integrate healthcare because, as been said to me by a previous politician, and it stuck with me, Russ, nobody's really interested how you organise yourself. They are interested what the outcome is. So we want, the lady who's sitting in Fiona Stanley Hospital ED tonight to get great care. And if they need great care in hospital, that they get great care when they're discharged as well.
I'm really curious about, if we come back to the premise of this podcast, which is where does courage need to show up? Where has it shown up? And with those challenges, what do you think if we were to task people who have any influence over health, which are many, what do we need to, invite them around being more courageous in?
I think health has changed. I think it has got more. I'm going to start from a positive, a glass half full, because I think it has got more courageous because the community are more involved. I grew up in an era where, when the doctor said, right, that was what we're doing, you'd have to say there probably wasn't a lot of informed consent like there is now.
So doctors, God were kind of, fairly close.
And as a doctor, and I think I met some of those people who taught me, I think there is much less of that to this day. And that's good because the community are more involved. Are there more gains we can make? Absolutely more. So actually get the community more. And that stakeholder engagement is not just about the community, it's about the clinicians, and it's not just about doctors. As I said, it's about nurses, midwives, it's about allied health professionals. It's actually about governments of the day. It's about the other sectors because we do get quite insular. So when we want to be courageous, don't just be courageous within your hospital. Think about who the other stakeholders are to make that patient journey much easier. Because if the patient journey is easier, life for the clinicians become easier. And I think we learned, again, COVID was a really good learner. When we went into that crisis mode, when we set up our emergency management teams, when we actually were in that 3 years, we cooperated with sectors we normally wouldn't cooperate with. So courageous, I'd also say, and this is my own personal view, I'd like to see more decision making, and that's not a issue for government. That's actually an issue for us all. That's an issue for people, coalface, managers, leaders. There is a tendency when things get hard when you're delivering a project like a Fiona Stanley Hospital or a brand new, there is an end point, and you're trying to bring everything together to get to that end point. And so usually there's a lot of stuff that happens towards the end. But when there is a more ethereal problem but very significant, there is this tendency sometimes to form working groups or go and look everywhere else, or, I call it a bit of blancmange, and, or semolina, and that shows you where I went to school. But there is this sort of, sometimes we'll go over here, we'll consult this, we'll do that. You do need an endpoint, and I think you do need to say, well, that's where we either stop the consultation or we make a decision from there. So I think that's where the courage has got to be. I am not saying consultation is not good. It is. You need to have it, but you also don't need to be bound by it if you have a critical decision that actually leads to better healthcare for the community.
This podcast is brought to you by my weekly newsletter, which is Donna's Balcony Views newsletter. This is a short weekly free newsletter that I write with the theme of building resilience and improving wellbeing. It contains 2 things I've experienced, 2 things I've learnt from others, such as speakers, podcasts, books or articles, and a personal story from someone else about what they do for their resilience or their wellbeing.
What I love about your newsletter, Donna, is it's really bite-sized and it's extremely easy to read. In a couple of minutes, I've got some great resources and some little tips that I might try. And I read it this morning again, and it just gave me some idea of what I could focus on, some morning questions and some evening questions, and I'm really enjoying it.
If you would like to sign up for my weekly newsletter, my free weekly newsletter, go to my personal website, which is www.donnasbalconyviews.com.au, or on Instagram at Donna's Balcony Views. Do you sort of feel that potentially working in government is becoming more risk adverse because there just seems to be a lot of scrutiny on every decision that people make?
It's a great question, Donna. I've been in senior positions in health for some time. I don't think it's getting worse because I think there are more, again, tools for us to be able to make decisions sooner. I think naturally, if I look at my own industry, it is a bit risk adverse. It goes back to we should be able to say, if people are taking decisions, and they shouldn't always be taken by the senior leaders. Yes, there are decisions that should be taken by senior leaders, but if people are taking decisions at a lower level through the organisations, those decisions were made soundly at the time, we should be backing those people. I think we are in a risk. I think, yes, look, there are agencies that are risk adverse. We're dealing with people's lives, so it's actually good to be risk adverse.
Yes.
But I always say, as one board chair, when he came into the role, asked me, well, what are the 3 things we need to do? Just give me 3, Russ. And there were lots of things I had to do. And I said, safety and quality, clinical performance, financial performance, those 3 things. And each year we need to be better. So our safety and quality. And we've learned a lot. We've come a long way. So I'd look at the real positives in health. Safety and quality, there are still things that go wrong in healthcare, but we have a reporting culture now. We didn't have that 30 years ago. We learned from the aviation industry. Let's keep that going. We don't want that going underground. Clinical performance, let's see what our clinical performance is like. We do publish it, and actually governments publish it. They publish every state. They publish nationally. And also you need financial performance with it. So health cannot just be this bottomless pit. You do need a budget, and leaders in healthcare need to stick to it.
I'm very curious to talk a little bit more about the COVID years, because that must have been such an intense period for you. So that we do have quite a few listeners outside of WA as well.
Yep.
So Western Australia was in quite a unique position. We sort of locked our state down, and we were in lockdown for a long time. The borders were closed for, what was it, over 900 days or something like that?
Yes, I can't remember. I can't give you that. I know we only had really pure lockdowns here, or complete lockdowns of really under a couple of weeks here.
Yes, with actually not being able to go outside our houses.
Yeah.
Yes.
Look, COVID, I think the results here were not just simply we locked ourselves away. They weren't. There were a whole myriad of things. I think it was, very good government leadership, and I think it was actually, from a healthcare perspective, I think we had public health. One of the things where we had public health at the senior level, so our chief health officer sits on our executive. Public health has always been a very serious business in Western Australia, and the agencies cooperated. So I must say, to my colleague Andy Robertson and friend Andy Robertson, I should say, because we spent a lot of time together, to the ex-police commissioner, now the governor, His Excellency Chris Dawson. The three of us spent a lot of time in those 3 years, and it was a great team, and we had great teams and we had adaptable teams. But it wasn't just about the actual agencies, it was about all the other stakeholders out there. It was, I've mentioned aged care, disability sectors, the mental health sector, the Aboriginal community-controlled health organisations. We don't really mention them as much as we should. They really were so well organised when it came to COVID. I mean, if anything worried me when Omicron came in early 2022, I wasn't worried about PPE. I wasn't worried about our hospitals being able to cope. But I worry, because COVID was a worry anyway, but I was worried about mental health sector. I was worried about the Aboriginal people. I was worried about aged care, and disability. But yet those sectors, we had time to prepare. So what that time before us gave us time to cooperate and repair. I don't want to give the impression it was smooth sailing. It was not. But those sectors really worked well. I think the community came with us. Great. The Western Australian community, wow, they came with us. We made decisions one day and we reversed them and we did something else. And we had to deal with things we never dealt with. We had to run hotels. I never thought it would be in my job description to run hotels or run 11 or 12 hotels. And also we had the largest number of ship outbreaks, or ships our public health teams had to look after, than any other place in the world. Not in the world, sorry, in Australia. So there are lots of strings to our bows, and we learned a lot during that. I also would say the marriage between the political leadership and the bureaucratic leadership, was second to none. And again, not saying that it was all plain sailing and there weren't disagreements, but what I am saying, it worked extraordinarily well. We spent a lot of time together, especially in those early days. So I think it was a whole mixture. I don't think, yes, there are two land borders, and yes, you've got aircraft, but we had COVID outbreaks. We had a community. We had the highest vaccination rate. Let's not miss the vaccination rate. The vaccines, WA actually led the way. So there was a whole series of events and a series of things. I think the final thing I'd say that we concentrated on was not letting Delta get in. So you would remember the backpacker outbreak in December 2021, where we were checking in backpackers to the Western Hotel. I always remember that, pretty well. But our worry was that Delta would get established. And we knew if we could stop Delta getting established, Omicron, which was, had much greater spread, but was much less severe, coming from the eastern states in the early part of 2022, we knew we would be prepared. And we got on top of Delta. And that's really thanks to the community, but also the contact tracers within the public health area of the health department. And there were contact tracers everywhere. There were contact tracers in Country Health Service, in our metro hospitals, and also in our health department as well. So it's a difficult. I mean, COVID. Again, I look back a bit with rose-tinted glasses, but I get brought down to earth by my family quite regularly when it comes to COVID, because it was constant.
Yeah. What sort of hours would you have been working for months on end during those initial sort of late March and onwards, when it was people were really quite frightened?
Yeah, look, it was in the early days. It was very intense because people were scared, and I remember. I mean, it's difficult to know, but it was every day. It was every evening almost. I don't want to overload this. I was the Director General of Health at the time. That was I happened to have a pandemic. I was there to get on with it and work with my other colleagues. And it wasn't just health. Every other public sector agency, you look at Department of Premier and Cabinet, you look at all of those. They absolutely threw everything to it. You had police. You had the aged care sector, the Aboriginal community control sector. This would have been right across the board. So I can't tell the hours. I just say it was. I sometimes look forward to the week rather than the weekends, because you never knew what was going to come. I think it was very intense in the beginning, and in the beginning, I think people were scared. You saw what was happening in Italy, you saw what was happening in France, and my main aim was to actually get enough PPE in here, to get PPE, so the staff knew, right, we've got enough PPE, so if it does come, we're not going to run out. And that's why we chartered a couple of aircraft that went to China to actually get PPE, so we had enough. I just wasn't prepared to rely on somebody else to get PPE here, got the testing kits, and the thing moved from there. I think probably the worst period was the first 3 to 4 months, because we didn't, you didn't know what you were dealing with. You knew about a pandemic. We had good plans here, but those plans were written for 3 months, not for 3 years. And I think we have done our own review. We will learn from this. So when the next pandemic comes, hopefully those who are in charge at the time will be able to say, well, this is what to do and this is maybe not what to do.
It seems as though the collaboration across government, across the agencies and just with the community was a key to that.
Yeah, it was. I mean, I'm not saying it was plain sailing. There were bits that really annoyed me. I think, there was elements of not the community, there were elements of community, but elements of the clinical community that would throw rocks, very, very small number. They were very much, and I remember saying this is a bit like, I think, and I'll mess this up, but what Franklin Roosevelt said, there were those people in the stalls who just threw rocks at people who were in the arena. Yeah. And I spoke to...
From the cheap seats.
From the cheap seats. And who actually... Because we had a lot of people who rang me, a lot of clinicians who rang me who were in the private sector and said, look, what can we do, Russ? What can we come and do this? And so we brought people in to do different things. People actually had a really good response. But I think there were a few who just criticised for the sake of criticising. So there were those... That was a bit galling, but ultimately, because and then we had the anti-vaxxers, which probably got more noise than it should have done. But, if you look at what the vaccination did, if you look at how the general community responded, and I mean the general community. I remember when we did have to go into lockdown, when we weren't taking flights in from other states, and we helped other states. We didn't become an island in the sense we didn't. Well, we did. I think that, but we didn't not help other states. We helped Victoria. We helped other states. We actually provided our contact tracers, and there was good collaboration. But ultimately, I don't want to give the impression it was all smooth sailing. But when I look back, that collaboration between the agencies and the community with everyone else went well.
When you look back on that period, what are your kind of thoughts on it? Is it something that one of your most difficult but proudest things to be involved with, or how do you sort of reflect back on that period?
Yeah, I think very, very difficult, but very proud. But proud of very proud of WA Health. Proud of 55,000 amazing staff who all just did. They came to work. They went the extra mile, 2 miles, 3 miles. And I think it wasn't just health, it was police, it was every agency, and it was the community as well. But I was just so proud of, and everybody sort of just, when something changed, when a new protocol came in or a policy came in, we knew it was hard, but everybody did react to it and reacted to it well. So, yeah, very proud. I'm very proud also of keeping business as usual going, and also the recovery. We recovered a lot quicker than other states, probably because we didn't have the effect that other states had.
Fantastic. So, Russ, you've taken us on quite a journey of your career, starting in Scotland over to, New South Wales, flying doctors, back to WA, north, back to Metro.
Yep.
What is ahead for you? What's coming up that you think you're going to need a bit more courage and a bit more resilience around?
Look, I haven't actually made any plans. I was very purposeful of that. I wanted to, when I left at the end of March, I'm taking a bit of long service leave, and then I will see. I've actually been really purposeful about not saying yes to anything really.
Has that taken courage to stop saying yes?
Well, probably has, because I'm, quite, from somebody who's worked worked ever since I qualified as a doctor and worked in really intense jobs, especially the last probably 20 years. Yes, there's a sort of what next? But on the other hand, I thought otherwise I'm not going to, what I call ratchet down, or declutter, or do the things I want to do. So I'm actually not sure. I love health. I love the sector. I'm extremely fond of WA Health, but I love the public health sector. And so I can't see myself too far away from health, but also, when I do something different, I want to have a much better work-life balance. And that's
that holy grail, right?
That's holy grail, which I wasn't very good at. But the when and if. So I actually haven't planned anything. I have sort of retired from WA Health, and I'll just see what the future brings. I'm at home a lot more, and I haven't been yet kicked out by my wife. So, day by day.
That's a good thing.
I'm gonna ask you one more personal question, if that's okay. So irrespective of where you go next and what you do next, what actually really matters to you now that maybe didn't used to matter?
I think from a leadership and a senior person or senior executive journey, what matters to me now, if I was giving some advice to somebody going into the role, I'd say, going into any senior role, do get on that balcony. I know it's a bit of a management guru sort of thing to say, but it is important. It is important to try and get above it all, to look at, especially if you're trying to solve some issues. I wish I'd listened to my gut feeling more than I did. I did listen to it a lot. So if there's something that tells you not something right, if you think there's a rat, you smell a rat, there usually is one. Your family, your friends are critical. So never, yes, they'll support you when you're very, very busy, but never let that go. And I think the other thing I would say is have that time, that time out. I don't know if that's answered your question, but I think that's what I would look into. If I do something in the future, I would try and certainly balance it, and also enjoy. I do want to enjoy a less sort of environment, which is a less relentless environment. I'm not complaining about it. I loved the role. I loved the Director General role. Not all the time, but I think it's a very humbling role to be able to lead the WA or any public health system for a period of time, and especially through a pandemic. And also, I'd say, make sure if you are a leader, you will make some mistakes along the way. It's okay. That's actually okay. It's actually knowing when you've done it, learning from it. All those things that you would have done maybe 10 years ago that you wouldn't do now, that's also okay.
Yeah, and I think there's probably another whole podcast on leadership and, in there as well, Russ, but we're really grateful for your time today.
Is there any last things that you would like to mention or?
No, it's been very nice talking to you about my leadership journey. I mean, I think the only thing I would say, Donna, is you're talking to one person who happens to have had senior leadership roles. I could not have done them and not had the successes or not even seen through some of the most difficult times without the team. So, and that team is not just at the second tier, and I was completely blessed at all times with those people who reported to me. They're just magnificent, and a lot of them you don't hear who they are, but they're just magnificent. But also the staff in WA Health. So, I ran into one of the nurse co-directors or nurse leaders the other day who was there on the day of commissioning, and did all that work before, and she's still hugely passionate about what she does. You've got a massively passionate healthcare sector, and I'm just proud to have been a part of that, one as a clinician, but also as a senior leader.
Excellent. Well, thank you so much for your time, Russ, and I shall see you on the running track.
You will do. Thank you.
Thank you. We hope you've enjoyed this episode today, and we really appreciate all of our listeners, and we know that these stories of courage and resilience are really impacting on people. So if you know of someone today that you think would enjoy or gain something from this episode, please share it so that our listeners can grow and more people can be impacted.
So, Donna, we've just interviewed Russ, and how is it that you know him again? You mentioned something about running buddies.
Yes, so he is in my running group, and it works out well because I am the slowest of the runners, and so in the warm-up, every single person passes me. Oh. And he passed me, and I said, how would you like to come on our podcast? And it does turn out that he loves listening to podcasts, so he was quite keen to actually be on one. So that was good. And last year, Russ actually did the half marathon, the Perth half marathon, and he'd done a lot of training, but he ended up having to stop about 6 times because he is a doctor. So you're obliged to help people, and it was a very unseasonably hot day, and there were so many people that collapsed. So if you are thinking of doing a running event and it's hotter than usual, make sure you drink a lot of fluids and be prepared.
Yeah, or if you're one of those people that Russ helped out on the day, you can have listened to the podcast.
Yeah, that's right.